all of this. So this is just a basic review of like the cardiovascular anatomy. I think what helped me as I started to learn more about hearts was to really think about the heart as two separate organs. I know that sounds crazy, but like the right side of the heart, the lungs, and then the left side of the heart. So right here, I focused in basically on the left ventricle, the aortic valve, and then going to the aorta into the body where the blood is pumped to the body. So normally, I feel like it's important to know the normal blood flow through there because anytime there's a problem like aortic stenosis, you will start to see the results of that with the backup of the flow or the increase of pressure. So as you understand the normal anatomy, you can even better comprehend when there's complications and what to anticipate with side effects. Just to review, as she said, aortic stenosis is an abnormal narrowing of the aortic valve. And what that causes is left ventricular hypertrophy. So as that valve narrows, the left ventricle actually tries to get stronger to help overcome that increased pressure. So you have an increased left ventricular pressure, and it causes wall stress on the heart and eventually heart failure. Like she said, there's a really high mortality rate if this goes untreated because ultimately these patients are going to die of heart failure. They're not able to overcome that pressure and push blood forward to the rest of the body. Some of the symptoms that you will see with aortic stenosis and why. So these patients may have chest pain, and you say, why would they have chest pain? So it's not like an occlusion, like they're not having a heart attack. So this is cause they have an increased oxygen demand. There's more muscle mass there, but there's not necessarily more blood vessels feeding that area. So they experience angina or chest pain related to that increased left ventricle wall size. They may have syncope, so they have a lower stroke volume, or the amount of blood they're able to push forwards is lower, so they're going to maybe be dizzy. And then ultimately, like I said, they're going to have heart failure caused by the decreased cardiac output and that increased left ventricular pressure. A little bit about what it is. She talked a lot about what it is, but it's basically minimally invasive surgical procedure to repair the aortic valve without removing the old damaged valve. So it inflates over the old valve, like she said. It's designed for patients that aren't candidate for or considered high risk for traditional cardiopulmonary bypass surgical approach. So really they're older candidates, which oftentimes they do have comorbidities, but so they're just not a traditional candidate for regular bypass surgery. So just looking at what things look like when they arrive to the PACU, this is just kind of, I think the goal is that they're going to try to stay with you guys a little bit longer than most of your patients. I think normal 2 hours is y'all's goal with patients, but they're looking at possibly 4 hours with these patients. They may stay in the PACU a little bit longer. And it's just going to be your traditional, what you would expect to do when you have a patient arrive. You're going to connect them to the monitor. You're going to get vital signs per the unit standard, review your orders. They're going to have the groin site checks. Like she said, they may not have just one insertion on, one groin. It may be both sides. And then they're going to be laying flat from 6 to 8 hours. I think that her order set currently says 8 hours, but I think she's trying to develop a specific PACU order set, so it may be a little varied. So I just put what our order set currently says for CVICU. And then hourly INOs, and then confirm the need for a loading dose of Plavix, and I'll talk a little bit more about the anticoagulation after this. Also, arrival, they'll do post-op stat labs. This is what we do currently for these patients. We do a stat CBC, CMP, and PT and INR, and then a 12-lead EKG on arrival to the unit. So I'm pretty sure y'all will probably be seeing these types of orders when they arrive to the unit. And then I just added this for reference, just of what colors the tubes are that you're going to send. These are some of the most common post-operative complications that you'll see with these patients. Like I said, they already have heart failure developed probably. They've already experienced these symptoms. So sometimes just going through the procedure, even though they've corrected the problem, it's not necessarily immediate. Like there's not reversal of what's happened. So they may experience some heart failure symptoms. They could have loss of peripheral circulation just related to the puncture sites. Or bleeding from the surgical side if they had to cut down anywhere. They're at risk for stroke, like we talked about, the calcification of the old valve, retroperitoneal bleed, just like any patient that's going to have groin or access like that. And then arrhythmias is probably one of the biggest complications that we see probably most frequently. Some nursing assessment things. I talked to her just a minute ago when I was asking questions about this, but like she said, you won't hear the click of a valve closure, so you should have normal auscultation for these patients. If for some reason you did have some significant changes when you're doing your assessment of this patient that are a worsening murmur or click or something, there could be something wrong with the placement of the valve, or you would want to for sure let the doctor know. So you shouldn't be hearing anything different on auscultation with these patients. And then hemodynamic goals are going to be per the physician's order, but typically we're going to try to keep MAP greater than 60 and then, heart rate greater than 60. Some nursing assessments for neurologic. We do perform the Glasgow Coma Scale in the ICU, and I think they were wanting you guys to probably do that also. Damon had talked about that. So just looking, I just put what normal is, so their verbal response on a scale of 1 to 5. Their eye response, can they open their eyes spontaneously? And when you use Epic, it pretty much walks you through what each number means. I probably should have given y'all a picture of that. And then assessment of their motor function. Can they squeeze your hands? Can they, flex their feet? Then we're going to do the assessment of the groin side. This will just be just like any angio. You're going to follow your unit protocols for their assessment of their pulses peripherally. They're supposed to lay flat for 6 to 8 hours per doctor order. And then just assessing for bleeding, hematoma, those types of things just around the surgical site. This is just a quick review of the signs and symptoms of retroperitoneal bleed, which I know y'all probably are more familiar with this even than I am, but bruising along the abdomen, sometimes that may be a later sign that you're going to see even an hour or so later. So really your pulse checks and development of hematoma and changes in their hemodynamic, their heart rate and their blood pressure are probably going to be the earliest signs. And then, of course, if you really suspected it, you're probably going to redraw your CBC and follow up with the doctor that. Just a little bit about the introducer sheath. I think that it's being called a lot of different things. It's basically like a cordis. I have the mannequin up here where if y'all want to come look at what that looks like. It does have a single heplock port usually that comes off of it that you can infuse through for an emergency. I don't think on 9 North that y'all access that port, but in the PACU you can infuse through it, and they may very well have, if you have any drips come out on the patient, they may be infusing through that port also. And it's just like a regular central line dressing. You want to be sure that it has a bio patch and it's dry and intact. And we'll talk about that when we look at it up here in a minute. And then assessing the location insertion side of the pacing catheter. And I'll talk to you just a little bit about that. So this is a little closer view of what it might look like. And all catheters have marking lines. So the thin lines are 10 centimeters and the thick lines are 50 centimeters. So for most patients, around 30 centimeters is actually going to be where the catheter is sitting in the right ventricle, which is where you want it to be. This is a picture of an x-ray. And so you can see down here at the bottom where it kind of just cups into the right ventricle like that. And that's the tip of it at the bottom is where you're going to get the pacing. And so if they do a post-op x-ray, this is what you would expect to see. Now, this is a left IJ entrance, but sometimes more than likely they'll probably be right IJ, so it'll go straight down and then cup into the right ventricle. So that's how you're going to get the stimulation. Over here on this side, I just have like what the markings look like. So 50 is the large thick line. So you should probably be somewhere around 30. And we can one-on-one look at this in a minute if you want, just to see the markings. I just wanted to give you a little introduction to what that's going to look like because it'll be part of your assessment of the catheter. With the removal of this, I know on 9 North you guys won't be removing it, but in the PACU you may remove it. It's just like a central line. When you remove it, the patient's already laying flat, so they're going to stay flat for this. But you would remove the pacing port first, and then the last part would be to take out the introducer. Yes, sir?
Right now, the policy states that we can't remove a cordis.
A cordis?
Because we have to get anesthesia to come and take it out before we take the patient.
Really? Okay, I'll have to talk to Damon. I mean, it's smaller than a cordis, like...
I think for right now, you're going to follow your unit policy. Right. I think as the phases progress, the idea is for you guys to do more and more. I mean, right now, phase 1, you won't even have these, but, eventually you should be able to remove them.
Right. And they may come out with this still in place, but I guess at this point the doctor would probably remove them. This is what a traditional cordis looks like. You can see how extremely huge that is. But if y'all want to come look up close,
This one's smaller.
this is more like just a central line.
Yes.
Yes, they call it an introducer or a sheath or a cordis. I think introducer. I think cordis is the brand name. But anyway, so it's a little bit smaller than what this actual traditional cordis looks like. That you would have a swan. So it is a little bit smaller. But I do think the goal is eventually to move for y'all taking these out. And I'm just. Yeah. Well, they may even go to the floor with this, and the physician would remove it on the floor if they kept it in place. But they're used to getting they sometimes get our Quintons and other IVs on the floor, but the doctors come remove them, don't they? Yeah. So this is just an introduction to that. This is how they would be paced. It goes through that line. Yes. Yes. So this is what it looks like right here. So it looks like you call it an introducer because you're, I guess, introducing the other catheter through it. But this green portion is the pacing line that feeds through there. So it has just a central line port where you can infuse, and then it feeds that catheter in. And this is what it looks like on the inside. Just a little bit about post-procedure. Oh, yes, ma'am.
Alice, can you use the microphone? Microphone, Alice. Thank you.
On the first phase of TAVR coming up to the front from PACU, we were told in the staff meeting that the first group of patients in the first phase must have permanent pacemaker.
Yes.
Okay.
Yes. That's the goal, is the first ones will have permanent pacemakers already implanted. This is just an introduction, so don't freak out.
Because eventually, it will come with this.
It will come with
This
this.
is an introduction, and then down the road, before we get to that phase, there'll be more training.
Correct. And then the people that are onboarded will also have the information.
Right.
So that's the goal. More
So
information.
don't get nervous. It's okay. This is okay.
Okay, so post-procedure anticoagulation, I'm just putting review MD orders first. Usually when they come to the unit now, one of the first things we're talking about is, did they get a loading dose of Plavix, or is that something that we need to try to get in the first couple of hours as they're waking up? So that'll be one of the first things that you want to know when they arrive in the PACU is, did they already give something or a loading dose while they were in the cath lab, or do you need to be planning to give that immediately post-op? And then they'll get a daily aspirin is what they'll be on, and then they'll start on 75 milligrams on post-op day 1, technically, which would be on the floor for a daily dose of Plavix. Now, if they're on warfarin, then there's no indication for Plavix, so these would be like a separate patient. So you just want to be sure to review the post-op anticoagulation orders for these patients, because just to make sure we don't miss that loading dose of Plavix. A little bit of pharmacological treatments for heart failure. So these patients, these are the 3 drugs that we typically use the most for heart failure. They're positive inotropes that help improve contractility. And so if the patient did happen to come out on one drip, usually they're on, I don't know, I want to say dobutamine. Yeah. And so they may come out on this drug. And so really what you need to be saying is this something we're going to maintain? We're just going to leave them on 2 mics per kg. They're going to go to the floor on 2 mics of dobutamine, and we're not going to mess with it? Or is this something we're going to want to titrate off before they leave the PACU and send to the floor? So this is what I want you to be thinking. Is this something we're going to be maintaining, or are we going to titrate it to wean it off? And what you want to be getting in report from Dr. Galano and your anesthesiologist as they come on board. I did give you a whole lot of information about these drugs, but I highlighted in red what I felt like was the most important. I just wanted to give you a review of this. So like I said, it's a positive inotrope, but just so you know, when you are titrating epi, you always want to be sure, one, when you're checking it, or if you're giving report off to someone else, that you're talking about the drug in doses, not we're giving 5 cc's of this or whatever, that, but be specific about what amount of drug you're giving. So all of our titratable drugs are vasoactive drugs, we here at UT Southwestern do weight-based. So it's always going to be mics per kg per minute. And that's going to give us specifically for that patient based on their weight. So you want to just be thinking, okay, they're on 0.02 mics per kg per minute. Like you want to be specific when we're giving a report to the floor and talking with anesthesia on what they want to do with this. Most patients are kind of sensitive to big changes with these drugs too. So when you're titrating it down, this is not a drug I would ever just stop. None of these drugs I would ever just stop this drug. You want to just slowly come off of it so that the patient has time to adjust in their system. With epi, you're going to see cardiovascular side effects. They can have tachycardia, they can have arrhythmias. And also what a lot of people don't realize is it can cause increases in their blood sugar. So if they do come out on an epinephrine drip, that may be something you want to start checking, especially if they have a history of diabetes. In the ICU, any patient on epi is almost always on an insulin drip if it's a long-term thing and we're not coming off of it. So I would probably do hourly blood sugars with this also. A little bit about dobutamine. It's probably the biggest culprit for tachyarrhythmias. That's what I would know. If you need to initiate this drip, that's what I would worry about. It has that chronotropic effect, which is increasing the heart rate or affecting the heart rate also. And then, of course, it's a positive inotrope, so it's going to increase the contractility of the heart and help pump more efficiently. So if for some reason you had to initiate this in the PACU, you could have, I've seen it in the first 10 minutes. It's pretty quick. Like if you start it and you may just need to back down a little bit and find out what works for the patient. But tachyarrhythmias is the one I would watch for with this. And then milrinone also, it's used a lot oftentimes with home therapy. So these patients may have been on home milrinone. They may come to you on milrinone, go to the floor and hopefully get off of it once they have the procedure and they have, relief from some of their symptoms. But the main thing is not to titrate these off quickly. You're going to kind of slowly walk down on them. Questions about those drugs?
And just to clarify, 9 North, we will not be adding on any drips. So you won't be taking an epi drip. You'll continue the same drips that you take, and we will not be titrating based on our exclusion criteria, just to clarify.
Right. Okay. Just a little bit about antiarrhythmics, because that is one of the most common post-op complications. I did give you a little bit. So amiodarone is typically the drug of choice for VTAC or AFib. Do y'all use amiodarone at all in the PACU right now? Ever? Typically, there's a loading dose, so you'll give a bolus, and then you'll start an infusion. That'll stay on as they try to transition them to a PO version of this. Sometimes these patients may already be on amiodarone like PO, but I just wanted to give you some considerations. It can cause decreases in blood pressure, heart rate, and just use it in caution if the patient is on calcium channel blockers or beta blockers, because it can potentiate bradycardia, so make them even more bradycardic. And then one thing is it also is called amiodarone toxicity. So if they start to experience unexplained pulmonary symptoms, sometimes it can be related to amiodarone. And they don't really know why, maybe some shortness of breath or something like that going on. So usually that's with more long-term use, but I just wanted to put it on there in case you had some kind of reaction with the drug if you had to start it. These are some other antiarrhythmics that you might see, but less likely. For diltiazem and esmolol, the main thing here is usually they're going to want to think about something else with these patients if they have a low ejection fraction, which they might. So just be aware if they want you to start, the patient goes into AFib and they say, let's start cardizem, and the patient already has a low EF and heart failure, you might question that. Like, are we sure this is the drug of choice that we want to use? Because it can cause them to go into cardiogenic shock. So these two drugs I would be a little bit more conscious with this patient population. But if you have a resident ordering, that might be the first thing that comes to their mind. So just be cautious with those two drugs. Any questions about antiarrhythmics? No? And I have more information, like some little drug cards that I can send to y'all or send to Damon and have them email out to y'all if you want more information about the drugs. But I don't anticipate you seeing these, but I just wanted to give you a little bit of information about them. Hypotension, it could be potentially anybody post-surgical. Often they will be a little bit hypotensive. I do know most of these patients kind of declare themselves either hypo or hypertensive after surgery. I don't know what y'all see in PACU. It's kind of the same way. They tend to run these patients a little bit dry during surgery, and so they may be very labile. So that's one thing in the unit that we do try to be prepared for as they arrive. They're probably going to need a little bit of fluid. And with heart failure, oftentimes during surgery, they are a little bit conservative with how much fluid, but as they have the new valve and they're like, okay, now I can function, they need the volume. So they may be a little bit labile with their blood pressure and need fluid initially before you would even think about starting a vasoactive drip. But the same thing is if they come out on levo or vaso, you want to be thinking maintain or titrate off. And now you may just maintain until they're stable and then titrate off because these drugs will not go to 9 north. And so they would just be for the PACU. So just looking at immediately what you need to do for your patient. I gave you kind of a lot of information on these drugs too, because I don't know how often you use them. And I think Damon just wanted to kind of brush up. But about Levophed, it is a very potent vaso constrictor that you just want to be sure you're giving through a central line, which is why I talked a little bit about that port, because you will have central line access more than likely for the patient while they're in the PACU. And it can increase the systemic vascular resistance. That's what you want it to do, but that, which means tightening things up. And so that will be important when you start looking at your pulses. If you're on this drug and you're having trouble, you maybe need a Doppler or whatever's going on with the patient because this drug is going to cause that. Vasopressin's the same, except it actually works through the kidneys. So the preload must be sufficient. So like I said, if they're dry, you really need volume when you're using these drugs. You don't want them just clamped down. So just be aware of those things. Any questions about vasopressin or vasoactive drugs? Okay, this is just a very brief introduction to pacing. This is not the first phase like we talked about, but I just wanted to give you guys just a little introduction of pacing and just review kind of some basic ACLS and even pacing through the crash cart, just in an emergency with someone if they had a problem with their AICD, which this could be for any patient. And I know some of the 9 North nurses are ACLS also, I think, or working on ACLS. So we're just going to review some of that real quickly. This is just the normal electrophysiology. So you're going to have the sinus node, which is on the atrial, that's going to generate atrial pacing, and it transmits to the AV node, which is where your ventricular pacing comes from. If you remember from that picture that I showed you of the x-ray, the pacing wire dips down into the right ventricle. So you can imagine that's going to be sort of an abnormal activation of, an electrical shock. So we'll talk a little bit about that. This is why you would pace, some of the reasons why you would pace. So persistent bradyarrhythmias, which would probably be this classification of patients, they're going to need to be paced for that reason, or post-cardiac surgery. This is a review of ACLS. So obviously the first thing we would probably want to try would be atropine. Yeah, we're going to want to give drugs first versus actually pacing transcutaneously shocking through the crash cart. Now, if that's the last resort and all we have, that's what we're going to do to stabilize the patient. But just a review of that, it does lead us to give drugs first, initiating a dopamine or an epinephrine drip, and then, go into transvenous pacing if possible. This is just the ranges for the drugs. So 3 milligrams is the max for atropine. So that's going to be 3 sticks. I think it's 1 milligram in the crash cart is what you get when you open it. So what you need to know when you start to think about pacing, no matter what kind of pacing it is, whether it's through the crash cart, through a venous wire, through a permanent pacemaker, you're going to have a rate, a current, you want to be synchronized, and then knowing your equipment. So these 4 things, if you're familiar with these 4 things, you can pace anybody. A little bit about capturing, because I feel like people kind of get bogged down in the terminology. I do want to show you this crash cart while we talk.
Yeah, if you have it, do it.
If y'all want to get up and come in up here, I'm going to put this other microphone on so I can move around.
I'll just bring this up here.
Can y'all hear that okay? Yeah, you can come up here. feel like it's easier to talk through it. So when you get ready to connect your patient to the, I'm just going to talk through the crash cart because it's the same concept no matter what you get ready to do. Okay, so right now this is a patient that's in sinus Brady. Their heart rate's in the 40s. Can everybody see okay? I can come around this way. So what it means to capture. So when the pacemaker depolarizes the myocardium, it generates the contraction. So you're always going to have a spike followed by a complex. That's how you know you have capture. You have a spike followed by a complex. So our machine is smart. Like I said, we always want to be synchronized. Have y'all ever cardioverted or seen cardioversion? All right, so the first thing you do is, I want to know what the heart is doing, right? So I'm going to synchronize. They're not in VFib. We're not just randomly defibrillating, right? They have a rhythm. And when you synchronize, you get these spikes right above each complex. So this says that the pacemaker knows exactly what the heart's doing, and it's tracking it so that we don't interrupt the normal activity and we shock at the right time, right? So when you get ready to pace on a patient, the most important thing is that you're going to connect your EKG leads because it needs a good EKG reading, and then you're going to connect your pads to your patient. The minute you hit pace, it starts to synchronize itself. It's smart. It wants to know exactly what's going on. So it said, okay, we're going to do at 60 beats. You know, we're at 40. We at least want to get to 60, right? A lot of times they'll say, let's pace it like 80. 60 is pretty low. And so then all you're going to do is you're going to start to increase the current because we have to deliver the shock. So as you see, I'm getting spikes there, but am I getting capture? No. So there's no capture. So I have a impulse generated or a spike sent, but no response. There's no response. So we need more volts, right? It's not strong enough. It's not generating anything. So as you continue to go up on that, hopefully, okay, now I'm starting to capture, right? So I have a spike and a complex. So that's how we know we're actually getting a paced rhythm on any beat. So no matter what you're pacing, whether it's, you know, permanent pacemaker, when you turn on your monitor and select pace, this is what you should see no matter what. If you're A pacing, B pacing, whatever, you're going to get a spike and you're going to have a complex that's generated. So that's how you know you're capturing, is that you're going to see the result. So failure to capture is when there's no result, like we just saw. So typically you need a stronger volt. So if for some reason you're pacing along and all of a sudden you're not, more than likely it's either connections or you need a stronger volt. Sensing. So when the pacemaker is able to identify the native cardiac activity, we already talked about that. We're going to synchronize so that the machine can sense. That's all we want it to do, is know exactly what the intrinsic rhythm of the heart's doing. We just want it to look at it. So there's 4 real main types of pacing, and like I said, the first group is really what we're going to focus on today, which is the permanent pacer. These patients are going to come out, they already have a permanent pacer, and then as we move forward, we'll talk about transvenous pacing later in phase 2. So transcutaneous pacing in an emergency would be what we would do. If their permanent pacer failed, or if something happened and it wasn't working and you had to pace through the crash cart, that would be transcutaneous. You're going to open up those pads. I did bring some. I don't know how familiar y'all are with these. They do have an expiration date. Also, if they come out of surgery with the pads on, which they do, I know a lot of times they come out with them on, they're only good for like 8 hours. So if they're in surgery a long, long time, you need new pads. You're not going to, if you start to pace with those and it's not working, you might need new pads because they will expire and they don't work. I think it says every 24 hours after 50 defibrillations, which sounds like hopefully they're still alive. We shocked them 50 times, let's hope they're still alive. But the gel will wear out on them and you won't get a good connection. I've only actually had to pace someone with a crash cart twice, ever. And I had to press so hard to actually get capture to achieve what we wanted. And obviously this is a short-term intervention. They're going to be thinking, do they need to go back to the OR? Do they need transvenous wires? Do they need to go to the unit? But this would just be to stabilize them and make sure that they're okay. And one other thing when you pace transcutaneously would be thinking about protecting their airway. This is painful. So if they happen to still be conscious when this happens, Protect the airway, sedation, pain medicine as you move towards how do we stabilize them and get them where they need to go. So other options first, we tried atropine, that didn't work. Everything else is failing, we're gonna pace them. And then just making sure you have a good reading on your EKG. Also, I think I just said that, but the connections, so it automatically synchronizes if you have a good reading of your EKG. This is just an example of what a paced complex looked like. You've probably all seen this, but like I said, when you have an abnormal activation of the heart muscle, it causes an abnormal QRS. So that's why oftentimes you'll just see that wide complex. Like sometimes you don't even have to have the pacer detect on to know, like they probably have a permanent pacemaker, because they may be getting abnormal activation of the cardiac muscle. So as that wire or whatever they have going on sits, and I have a few pictures of what, let's skip to that. So this is just a picture of a permanent pacemaker. So you can see kind of like the transvenous wire. See how they have this big loop down here? So it's kind of an abnormal activation of the heart muscle the same way as transvenous pacing would be. And if you're wondering, you know, sometimes you get report and people say, oh, it's an AICD, it'll shock, it won't shock. How can you know? So this is a permanent pacemaker, and you can see here's the atrial lead and here's the ventricular lead. And you see how this is coiled right here? That's the defibrillating part of their permanent pacemaker. So this right here, this permanent pacemaker doesn't have a defibrillator. You see how those are thin wires with no coiling? This is where they're delivering the shock just to pace, and then this is where they would deliver a shock to defibrillate. So when you grab a glance at their X-ray, if nobody tells you, you can say, oh, okay, I know that this has shocking capabilities. This permanent pacemaker can defibrillate this patient if they need to. And oftentimes, like, pace them out of it. So if you have a patient that's having arrhythmias postoperatively and they have a permanent pacemaker, you want to know, do they have defibrillation, you know, capabilities? So you can look at the X-ray and tell, can everybody tell the difference there? This is without. You can see the thin wires, and then this is with. You can see here's coiled and there is coiled. So it's like cupping the heart to shock it. Everybody good with that? This is what it looks like for a TAVR patient that just has a single wire. They will be paced in what's called VVI mode, and we'll talk more of that in the second phase. But you can see it's just a single wire sitting here in the right atrium. So that's what it looks like on their X-ray if they had just a single pacing wire. And then everything else, temporary pacing, will be phase 2. What questions do y'all have?